Morning everybody and welcome to the Health and Adult Social Care Scrutiny panel. Apologies for absence, we've got Councillor Zaman and Lynn Keedy, apologies. Minutes of previous meeting. Can I thank members of the panel who were here last time? Unfortunately I couldn't be here, but thank you very much. I understand that it was a very good meeting. And that some of the actions that were recommendations for at West Yorkshire level have been taken up at a West Yorkshire level. So thank you very much for that. Are there any points on the minutes that anybody would wish to raise? No? Do we approve those minutes? Yes, thank you. Are any interests that any of the panel members wish to declare?
Yes, under item 4. I'm an ordinary member of Locala, along with several thousand other people. Thank you.
Thank you. And all debates are in public, so we agree that public can be admitted. Thank you very much. Right, okay, let's move straight on to the Kirklees Community Services Review. And we've got Helen Sevens from North Kirklees CCG, who's here for both CCGs. Yes, okay. Yeah, all right. So, Helen, do you want to do a bit of an introduction first, and then we'll move to questions? Okay.
So, good morning. Before you today, you have the paper that was presented to both governing bodies in January, in public, which identifies the processes the CCGs will be going through to make a decision about the community services contract. On October the 1st, 2018, we entered the 4th year of the community contract, which is currently delivered by Locala Community Interest Company. And the whole contract is currently 5 years, with the potential to extend that by a further 2 years. So, in good orderly fashion, we wanted to plan a process to evaluate the current contract, to be able to make a decision whether to go to market or whether to extend the contract for up to a further 2 years. So that process was taken into the governing bodies, and that's included in this paper. So the options that will need to be considered, and this is part of the process, is whether we do nothing, just let the contract come to an end, extend the current contract keeping the existing service specification and contract terms, extend the current contract but within the framework of the contract revise the specification and outcome measures that we want to achieve. We could go to market immediately by keeping the existing specification, or we could go to market with a new specification. However, there's been such significant changes within the national and local agendas that we want to ensure that we're giving the best possible options, and one of the decisions that we could take is to look if there's a case for change to be made to extend the contract. So that was also offered as a potential to the governing body as part of this process, which we discussed in January. If we want to make a case for change to extend the contract, there's some key criteria which are contained in the paper that we would need to consider, and to provide any evidence about whether we are achieving those or not, which will then help with the decision to either extend the contract or go to market in April. As part of the process, there's some key evaluations going off. That relates to the community workforce, matrons, district nurses, specialist nurses, physios, OTs, other therapy services, and also about long-term condition management and the other services that Locala provide. So to carry out that exercise, we've done a desktop review looking at evidence and best practice and how Locala fare in relation to that. Also about the quality and performance of the service, so looking at patient experience, quality of services provided. Have Locala started to deliver the transformation that was expected? We're also looking at what service models for the future we may need to be able to put in place, especially in line, we've just received the NHS 10-year plan, and there's just in the last couple of weeks we've received the 5-year GP contract reform, which all indicate a different model and way of working within community. So we need to take in all that into context as part of the review process. Locally, we've also agreed our health and wellbeing plan and our integrated commissioning strategy, which again identifies a different model and way of working that we need to put in place to enhance and develop community services to deliver more services at or closer to people's home. That's the national direction of travel. It's very strongly our local Kirklees direction of travel, and our place-based developments offering support and health at the earliest point, building on people's strengths to deliver place-based care to meet people's needs. As part of the process, we've also done an extensive amount of engagement, and within the paper you'll see where we were at in January. There's a number of other further engagement processes happened. Today's part of the engagement process. Kirkwood Hospice, Mid Yorkshire Trust, Curo Federation, My Health Huddersfield and Health Watch have also been engaged in this evaluation process. So unless anybody's got any questions, shall I leave it there? I thought you may have. This is about a process though, isn't it? About how you're engaging and how you want me to take messages back into the CCGs. Thank you.
Yes, we have a list of questions. So Peter first and then Alison.
Thank you, Helen. I'm pleased to know it's going to be good and orderly and good. And I think that's very important to get that sort of slogan out front. But more seriously, really, when we come down to option appraisals, which is really the section 2.1, we've moved philosophically from an era when this contract was originally set up, which was about competition, to one that's about cooperation. And I just wondered, with option 3A in mind, how much blue skies thinking is likely to exist to really say, well, look, let's give this resource to the people who really know how to use it, which is the acute trust. Is there anything quite so radical, or does that defy good and orderly and good?
I haven't got an answer to that today. I think part of it is the evidence base of where community services are provided. They're not only provided by acute trusts in some part of the country, they're also provided by pure community trusts or community and mental health trusts in the community. Personally, I think the view is, have we invested enough in community services as a system? Nationally, there was an indication in Parliament a few weeks ago that we haven't kept pace in the development of community services as we have with acute trusts. So that's probably part of the decision making. We need to evaluate what the investment requirements may be and how we meet the needs of individuals.
Well, that brings us immediately to 2.9 really, and to the points that you raised. And if you could tell us, if you're able, what had been, I mean, care closer to home seems to have dropped below the radar as far as the public in this town are concerned. Can you tell us what the successes have been? What are the service gaps and what are the areas needing attention? We've asked several times of Locala, when we've met with them previously for, and I know this is difficult because they're not here, we've asked several times for performance outcome measures and they just haven't had them.
So as part of the evaluation, we've looked at both national and local key performance indicators and concentrated on the key performance indicators in the contract. That will be part of the full evaluation. It's not quite ready yet to share. As soon as that is, we can share that. The indications are that Locala have met the majority of those key performance indicators. Where they haven't met them, we put plans in place to get them up to achieve the performance indicators through the contract management board that we have in place across both CCGs. So that will be shared as part of the full evaluation report for the governing body for March the 13th.
Just one more. So, I mean, could you not be a bit more specific and say, well, look, we are saving people from going to A&E by this number. We are avoiding admissions for acutely ill people. We are better managing chronic disease and reducing unnecessary admissions. We are managing the frail elderly. We are saving bed days. I mean, surely you should be able to point to some broad criteria as to whether it's care closer to home is actually working or it isn't.
So as part of the evaluation, some of those measures will be used. So like ambulatory sensitive conditions, and there's two of them, aren't there? Ambulatory sensitive conditions and conditions not normally requiring hospital admission. And we've worked with Locala on developments to ensure that people that are on their caseload are not being admitted or only attending for short periods of time. That was evaluated at the end of last year to show the impact that had had, and it had saved bed days within the acute trust. And will that will then form part of the evaluation?
I think what we need is that most of us would prefer to be treated at home, and I'm not sure we've got that reassurance at the moment.
We can evidence that as part of the report.
Hello, my question relates to 2.5, which is a move towards population-based commissioning and built around the needs of local people and delivered by a collaborative of providers. And I just want to know how that's going to work and who's going to coordinate. Who's going to coordinate it? How is it going to be coordinated? Thank you.
So that's part of the local ambition within the health and wellbeing strategy, and has also been reinforced by the 10-year plan and the new 5-year GP contract. So there will be the development of 9 primary care networks across Kirklees. There'll be 4 in North Kirklees and 5 in Greater Huddersfield CCG. And they'll be on a geographical basis, which is the term used is contiguous. So they'll be touching but hopefully not overlapping. That is just about there. There will be very slight overlaps, but that's because of populations of where the movement are into practices. So those 9 networks are now established. Some are working quicker than others in identifying their needs of the population and specific areas they want to work with. The new GP 5-year contract that came out a couple of weeks ago very clearly indicates that primary care networks will be developed, and that by May each network needs to have formed and they need to sign up into a contract for a direct enhanced service. So primary care networks will be supported through the GP contract as well. Through that process, it's seen that GPs are leaders of that network, and each network will need to identify a clinical lead to take on board that leadership role and bring together partners across that local system wrapped around the needs of patients to be able to meet the needs of patients and deliver multidisciplinary team approaches, which will include community services, social services, the voluntary sector. Over time, hopefully partners from the acute trust will be involved as well. So it's very much place-based on that local population basis, and it's based on national evidence and good practice from other parts of the country.
Sorry, so just to get I've got a grasp of what you said. It's so you're placing the onus upon basically on GPs to actually bring all this together.
GPs will have the clinical leadership of bringing it together, but they will be supported by resources from in the CCGs and other partners to wrap around to support that on a managerial basis as well. It's still early days, and those discussions are still happening about how that will operate.
So, is there any? So, are you going to come back to us with more information when you have it as to how it's going to be, how it's going to operate, basically?
Yes, when we came for the integrated commissioning review, was it November? We said primary care networks was a key area that we would bring back to scrutiny to ensure that you're updated and you're part of that development.
Okay, thank you.
I don't know about anybody else, but I'm confused. Okay. So, the Care Closer to Home contract, which is what Locala has, is commissioned by the 2 CCGs across Kirklees. But then you've got the GP networks, 30,000 to 50,000 people. So if we take, for example, podiatry, because we've had podiatry before, that Locala said they needed in certain places in Kirklees, the podiatry clinics, okay. So if these areas of population-based commissioning, if the GPs came together and said, for instance, right, okay, in our area we have identified there are these particular needs, and in actual fact we need more podiatrists in our area, for example, or less podiatrists in our area, who then will commission that? And how do you know that you've got the capacity in the overarching Kirklees contract to help deliver what the population-based needs are that the networks are going to identify? How does it all fit together?
They are very good questions. I think we are still working through how that will operationally work, because there'll be services across Kirklees which will need to be delivered and provided across Kirklees, because they're probably smaller numbers of people will access those services. So to put things down at a very local population level may not be viable. So I'm just thinking, for example, there around the intermediate care beds and services, that will be a Kirklees provided service, and we'll need to look at how that meets the needs locally, but it will be provided across Kirklees, because we can't put those services down to a local level. The CCGs with the primary care networks and other partners will work through about the process that we will need to put in place to ensure the questions that Councillor Smage has asked are implemented, and that we're balancing the needs of the very local population with the whole of the Kirklees population, and then also identifying and using those resources effectively as well. It's still very early days, and a lot of things have got to be developed and thought through, which is why it's keen to think about which way we go with the community contract, and is it the right time or not, which will be the decision of the governing body, whether to go out to tender or not, when such other changes are happening in the area.
Yeah, I've got 3 questions. First one's on paragraph 2.6, where there's a reference to having to operate within a smaller financial envelope. Whether the contract's extended or retendered, do we know how much smaller the financial envelope will be from 2020 onwards? And do we know whether there will be services which are currently delivered, which won't be delivered in the future because there won't be the money to deliver them?
So this was written before we had the NHS long 10-year plan, which identified that over the next 10 years and in the allocations over the next 5 years, CCGs were directed where possible and where there are resources to be able to invest in community services. So we've had that very clear direction. So we'll have the baseline starting point, and as part of the evaluation process, the value for money will be looked at to see if we are getting value for money. Are we benchmarking from Kirklees with what other services are provided in community settings across the country? I don't know the answers to those yet, because that's built into the evaluation. But we've had a clear direction of travel that if we have resources to invest, we should be investing them in community services. So perhaps that's changed slightly since that 2.6 was written.
Yes, so presumably that can be emphasised in the consultations that are taking place, that financial position has changed somewhat. Second question is, this is all about integration of community services. There's hardly any mention of social care, and that's such a critical part of delivering services in the community that that appears to be a pretty big gap.
So that has been recognised, and we've done further engagement, obviously my joint role and with the council, around what it will look like at a local population-based level. So social care, in the provider side of social care, are looking at about their teams and how they potentially wrap around the primary care networks as well, to enable this direct access to social care support as part of that multidisciplinary working and that smaller population base. So social care colleagues are working with some of the primary care networks already to look at the population needs and how they can work together to provide sort of step-up help and support to prevent people going into hospital, and also ensure we've got supported discharge at an early stage.
I appreciate that. And this report is a report by commissioners. If there's to be proper integration, would it not be useful to actually have the local authority involved in this process as a commissioner, so that then the commissioning processes can be integrated across the 2 sectors?
Yeah, a piece of work has started separately to this, because obviously this is around this specific contract, but there is an ambition to look at how we integrate commission across with health and social care. So we've started a piece of work identifying all the services, obviously both sides, it doesn't sound the right approach, but both organisations, all 3 organisations are currently commissioning, to look what in the short, medium and longer term we could start to commission together, or at least align intentions, so we're doing it once, so we can look at, make sure there are no negative impacts or risks of one organisation doing something that has an impact on another. And that list, actually, if you think about it as a Venn diagram, we've got a bit overlapping already because we've already got the Better Care Fund and a number of pool budgets in Kirklees, Community Integrated Community Equipment Store, what some of the services in the Better Care Fund are already jointly commissioned. The ambition is those things that are on the other sides of the Venn diagram then come into the centre. And when we've done that, started that piece of work, it's just probably the statutory functions of organisations that potentially would not come into that joint process. But we can bring an update back as part of the integrated commissioning into scrutiny.
Thank you. The third question is in paragraph 213. There was a reference there to getting back to a position where the system takes a holistic and not task-focused approach. I was intrigued by the getting back bit because I'm not sure we've ever had that. Is it moving towards that?
Yes, moving towards. Obviously, yeah. I think in some areas people would say they did have a more MDT approach when staff could be based more locally with people and you could have conversations in a building together rather than having to do something now on a computer where things feel very task focused. I think it's about having that conversation around an individual patient together.
Just to come back to the primary care networks, are you saying that by May all GPs' contracts will depend on them being signed up to a primary care network?
My understanding, and I need to probably read the data, and our primary care colleague is not here to be able to fully confirm that, but my understanding is within the new contract, it's by May they have to sign up to a network. But we can check that and qualify that and come back to you.
Yeah, just to go to 218, please. And I wondered, there are various very important criteria there, various dimensions of decision making. And I wondered, coming back to the point about contiguity and interdigitation and all this business about coordination, whether there was ever going to be a forum where you sat down representatives of general practice, of the acute trust, of social care, and of the current community providers or the future community providers. Are you ever going to sit them down with care closer to home and ask it what it means to them? Because we've been given an impression that there would be this seamless care closer to home. And we're not sure if it exists or not. Thank you.
So with the integrated commissioning arrangements we've developed across Kirklees as a place, we've also developed an integrated provider board whereby colleagues from the acute trust, the mental health trust, the voluntary sector, care homes, domiciliary care providers, Lacala, social care, all now meet together on a monthly basis and have identified key areas of work that they want to prioritise in working together. As that evolves and develops further, the aspiration is that, how we describe it, will start to happen on a Kirklees basis.
Thanks. Paragraph 471, which talks about potential conflicts of interest during the commissioning cycle. It says there that some work's been done on that. Is it possible for us to see what the principles of how that's actually going to operate, what those might be?
So yes, so we have conflicts of interest policies in each CCG, and we have a governance lead who advises on those policies and how they should be implemented at each stage of the commissioning cycle. So how we started this evaluation, we have adhered to the policies and principles in there to be able to manage the conflicts. We can share the policy. We can share the conflicts of interest policy.
Yeah, and then just a question on paragraph 210. There are some of the organisations listed there I'm not quite sure about. First of all, there's reference to clusters, which I assume are GP clusters in North Kirklees, but there doesn't appear to be anything equivalent for Greater Huddersfield. Secondly, North Kirklees Council of Members, I'm not sure what that is. And then thirdly, which is the next paragraph, in fact, I don't know what CURO is.
So the clusters are like the pre-runners to the primary care networks. There's been some tweaking of where practices are in which cluster to make the primary care networks in North Kirklees. And for Greater Huddersfield, it should be down there as about the commissioning event. They come together as practices as well. But I do know one of my colleagues been to a number of individual practices in addition to going to the clusters and the commissioning teams in Greater Huddersfield as well. The second question was Curo. Curo is the GP Federation in North Kirklees. So each practice is a member of the GP Federation, which is called Curo. There was a third question.
The other one was the North Kirklees Council of Members.
So again, the Council of Members is made up of individual practices, and it's where we meet as commissioners to commissioners of the GPs. So Council of Members, when we have a conversation with them on a bi-monthly basis, we should be talking about commissioning with them in those meetings.
So again, is there an equivalent for Greater Huddersfield?
They haven't got a council of members in a Greater Huddersfield, but they come together on that basis in a quarterly meeting to operate in the same way. It's just not called, they haven't set up a council of members in Greater Huddersfield, but they still come together as a general meeting, either once a quarter or once every 2 months, to operate in a similar way. My Health Huddersfield is the GP Federation in Greater Huddersfield, and it's all member practices, so it's providers coming together under the umbrella of the GP Federation.
I think it might be helpful if there's some clarification of that paragraph then, particularly if this is going out more publicly as part of the consultation process, because it's not clear from that list that there's a kind of equitable distribution of consultees across Kirklees as a whole.
I just wondered, within that mix of organisations, how out-of-hours services are catered for, please?
Sorry, how? So how we haven't so we have. Yeah, yeah. So after 6:30, yeah. So some services do operate 24/7. Local operate 24/7, and the Kirklees operate 24/7. And we also commission LCD and 111 out of. Well, 111's a 24/7 service anyway, which is the starting point and the pathway. And then there's Local Care Direct, which is commissioned out of hours. Yeah.
I mean, can I just ask about GP deputising or GP cover during those periods, please?
So that is covered by LCD, the contracts with LCD, from a review of the GP contract a number of years ago.
I just had a query around about what the test will be for us to know that that the process has been managed effectively and properly.
From the CTG's perspective, that we've.
Yes, this is clearly a huge undertaking. So how will we, the public, and how would we here at the council know that this has been managed effectively? What will be the test, basically?
So we, as part of the evaluation, we've had a whole programme plan developed about what the evaluation process will be. So the assurance we can give back is the content of that plan, and have we actually adhered to it, and have we actually delivered the results of the plan to be able to then make the evaluation process.
Okay, thank you.
Talking on your engagement, okay. It's very medical based, the engagement at this moment in time, I think. So, and Locala, are you engaging with the different teams on Locala? Are you just engaging with Locala as an organisation? So how do the different teams in the different services that Locala operate feel are operating okay? But there's no patient groups or health watch here or anything like that. And so I think we'd want to know how you're going to evaluate, because what you've got to do is you've got to evaluate that about the performance and the service model and the quality of care that's being provided at the moment, haven't you, to see if you can take that forward. So while you're getting a medical perspective, how are you getting the user perspective?
So Health Watch are being engaged in part of the process, and our engagement colleagues have reviewed all the engagement that has happened over the past 5 years with patient groups, patient reference groups, specific pieces of engagement or consultation that's taken place from the CCGs and also Lacala, and that's been brought together into a summary report which has drawn out key themes. Part of that has been about quality of service and also some patient experiences in there as well, and then how we as CCGs have acted on that patient experience feedback and potential changes that have been made. So that report's currently being drawn together and will be a key part of the decision making for the CCGs.
So are we saying that basically we're using Health Watch reviews, patient reviews that have been collected over the last couple of years to base the report for this? So in terms of Locala, the current package that we've got for Locala, we're just basically, because the reports that we've had from Health Watch have been a collective of reports for everything, not specifically just Locala services or these particular services that we offer. So are we not going out to the patients to say, these services, what do you feel about these services? Is there anything we can do better or anything like that? Is it just a collective of what we've used before?
So we'll be using the Health Watch reports as you've just described, and that conversation is happening to be included. And then some of the engagement we have done and Lacala themselves have done will be used for the evaluation report. So some of that will be specifics. We'll be using the friends and family tests that Lacala collect. We'll be receiving specific patient experience and stories that have been collected and evaluated. We'll also be using, as I've just described, where the CCGs have gone out and asked specific questions of specific groups at times in certain areas. For instance, the podiatry consultation will be used as well, and there's been other areas of work. I haven't got the whole list to hand, I'm sorry, but we can provide that as part of the full evaluation report.
I'm just trying to figure out how we're going to use something. The good collective report that was basically in something that we changed in the last few months, and we've received a patient's feedback saying it's fine. However, and it's only for one particular service, i.e. podiatry, I'll be using it as a collective for the rest of it. If you get what I mean.
Yeah. It will be specific to that service. The other thing that's been happening is there's been some patient walkabout. So, as a CCG, we go into specific services and do a walk around and speak to patients. That's been acted on over the last probably 3 years with Lacala, and all that information will be drawn in and fed into the revaluation report as well.
Can we ask navigation through services, the ease of navigation through services? Is this going to be taken into account as well as part of your evaluation? Because it can be quite difficult for people to know where to go to get what services. And if you're asking people about a particular service, podiatry for instance, or district nurses or whatever, they're going to know how to contact that particular service. But are you asking people how they navigate through services, especially when they've gone from acute to care in the community? How can people get the best services and know who to go to? Because I know there's a single point of access for Locala, but you can have one service coming in at one time, another service coming in at another service coming in at another, and your head spins sometimes as to where you are with whom. So are you going to assess that as well?
To be honest, I'm not sure that's been part of the evaluation. I'd have to go back to quality colleagues and ask and check that through, but it's something that we can make reference to and ask for further information.
Can we return, please, to your ambitions for care closer to home, to reduce the need on acute-based services? So part of this about delivering improvements and has the service delivered key indicators and outcomes. When you were talking about this, you were talking about saving bed days and that services people have been receiving in the community had not resulted in hospital admissions. But it's the other way as well, isn't it? That people can have a quicker discharge if the care close to home is in place, and the readmissions as well. So how are you evaluating that and the ambition that there would be savings within the acute trusts that would be part of reconfigurations, etc., on both sides of Kirklees, that the care closer to home contract has achieved or is on its way to achieving its ambitions in that area?
So on the north side of the patch, and Collinsworth, Yorkshire, there was an evaluation of meeting the challenge implementation of the acute hospital review, which indicated that there had been some bed savings and beds were reduced in the acute trust with Mid Yorkshire. It wasn't till the level we actually planned originally, but there were some savings identified, and that was evidenced by the fact that additional services at that stage had been put into the community to reduce those admissions and support early discharge. There is still more to do, and I think that's recognised. Obviously, there's the engagement consultation with right time, right care, right place, and again, there's an ambition there to be able to develop community service to have that same impact on the amount and number of hospital beds that will be required going forward. So there is some evidence. We need to build on that, but there's a recognition that we'll need to be able to build capacity and staffing and working on an MDT basis to be able to deliver that in the community. We have evidence of this winter whereby we know numbers going through the accident emergency is up. I was talking to colleagues before this meeting, but actually the number of super-stranded patients, which is patients that stay for longer than 21 days, is coming down. So it feels like as a system we are working together, and that's on both sides of the patch, the super-stranded patients. We are working better as a system, and flow of patients is better, and people are getting the discharges that they need to ensure that their needs are met in the community.
Just ask a question about timescale. It says in paragraph 121 that you require a decision next month. And I assume that's a decision about which option to go for in 2.1. That seems quite a tight timescale given that consultation or engagement is proceeding as we speak. Is there sufficient time to complete the engagement, to learn the messages from that, and then to make a decision in March?
So we've had assurance from all people that are engaged in the process internally in the CCGs that that timescale can be met. Reports are being drafted, and as the engagement continues, that's being fed into the drafts of those reports. And we have a governance process internally whereby we'll meet that timescale to make the decision in March. That's the current plan.
Can we ask as well, because at Scrutiny we've had cases of some services where the information that came from the previous contract has not been reflected in the actual demand that the CCG has seen. And so, and you've had to put extra money in. I'm thinking about specialist wheelchairs in particular. You've had to put extra money in to deal with that problems there. So in this review, are you also looking at whether there is adequate resources in the contract? If you're going to, if one of the options to extend, for instance, is taken up, that there are resources in the contract to be able to meet the demand going forward during the extension period?
That's the piece of work that's also currently happening with finance colleagues and also service planning colleagues to take into consideration what capacity is required to meet the needs of the community going forward. And that will be part of the Right Care, Right Time evaluation as well, where that capacity is being planned through.
Just on 2.13, please, just for completion. You say in bullet point 2 that there's concern over morale and service skill mix and numbers, and I wondered if you could comment on how that is in the light of, take that inter alia, with the concerns that CQC had about those very things when it visited last time.
So that's been recognised and that's been closely monitored through the quality board of the Locala contract, and we've had updates and reports and looked at the staff survey since the CQC visit, and that's on an upward trend, which is really positive, that staff morale, training, supervision, etc. has increased and developed since the CQC visit.
Thank you. I ask it solely because these services depend on the goodwill of the people who work in them.
Any more questions, anybody? No. So, points that I've got then, and let me know if I've not picked up anything that you think about. So we'd like to see the conflicts of interest policies. We've talked about more of a role for social care, so a closer working together between the CCG and the local authority in this provision of this contract, commissioning of this contract, so that there's a more seamless approach to things for users of services. I think we'd like to understand more how you're going to deliver the contract going forward, and what your plan, a better plan of how you're going to develop that contract model. So if your options are to go to market or to extend the current contract, if any of those decisions are taken there, or they do nothing even, we would like to understand how you're going to develop this contract going forward, and what your plan is. And your strategy, Locala strategy documents that's mentioned in your report, we'd also like sight of that as well at some point. And we would, if we could, we'd like that sooner rather than later. But if it comes under contractual arrangements, etc., then we would have discussions on how Scrutiny could do that. All right, okay. Julie?
So I'd like to ask, I just read on 2.13 as well that it says how to better share records and information and improving communication between providers, and that's something I've heard so many times over so many years. And if there is work that's trying to improve that information sharing, it would be something I'd be quite keen to hear more about.
All right. And we would like to understand as well the assessment of how care closer to home has been helping with the hospital reconfigurations, and we'll do that going forward. We would like, I think, a better explanation on information on that as well. And your engagement, more users, patient groups, etc. Health Watch you've mentioned, but also the out-of-hours service. What's happening on the weekend? Is the service providing during the week causing a problem for weekend work, or is it helping reduce the demand? I know the district nurses work 24 hours, and many of the services in Locala do, but how is that demand being managed? And is there an impact on out-of-hours as well? All right, have I missed anything that anybody thinks? No, yeah.
Could I just ask, have we ever seen the mapping of these clusters, the PCNs?
We're just about there, we can share that. Yeah.
So a sharing of the mapping of the clusters. Okay, all right. Thank you very much. Have we got everything then that everybody's... Yes? Yeah? All right. Thank you. Helen, for that. Right then, we'll move on then to ambulatory emergency care at Mid Yorkshire Hospitals. And we've got Trudy Davis and Michelle Erdley. It's a bit like Smage. You can pronounce it several ways. Thank you. So item 5 then, and Helen is staying for this item as well. Thank you very much. Right, do you want to give a brief introduction, and then we have lots of questions for you? Okay, thank you.
Good morning, thank you. Please accept apologies from Dr. Richard Shepherd, who has been unable to attend this morning but has been quite keen. If there are any particular clinical questions, we will take those back. So this paper is a follow-up from the visit that we had here in September 2018, when we centralised the ambulatory care unit on the Pinderfield site. The rationale and driver for that was very much around staff availability and our need to train and recruit more staff. The paper outlines any progress that we've made in that recruitment and training, and highlights that there's still a gap in our staffing. We have a lot more work to do in regards to the provision of service, but we need to look at same-day ambulatory care in its totality, as has been outlined in the most recent iteration of the NHS plan. So there are other services that have been put in place on the Dewsbury site to support same-day emergency care, which don't necessitate patients accessing the unit as a specific place, because we can provide the service and pathways. We had a meeting last week with our CCG colleagues from both Wakefield and North Kirklees, with GP representation, to talk about how we get a really clear and full picture of the activity that's going on at Dewsbury, because there have been a lot of improvements, particularly over the winter, to make sure that we don't unnecessarily admit patients when they could be managed at home, and Helen's described some of that activity, and how we work closer with partners to ensure that patients don't remain in hospital when they can go home. And that work has been really very successful. There's still lots to do. It would be wrong to sit here in front of you and say that we can't make improvements, and I'm sure you'd challenge me on that. But certainly the length of stay has reduced, the proportion of admissions has reduced, the number of super-stranded patients has reduced, and that's part of the package of services that we're now offering for same-day ambulatory care. So our next phase is, our recommendation is to maintain the centralised service at Pinderfields for the next 6 months, while we continue to recruit and train more ANPs, those are the advanced nurse practitioners. Review in totality the provision of same-day emergency care with our partners that's available both at Dewsbury and Pinderfields, and look at the impact of the enhanced services that we've put on site, such as the direct access to frailty, how our GPs are accessing the operations centre, what improvements we can put through the operations centre, and overall collaborative working that links to many of the things that Helen has outlined. So Michelle and I are more than happy to try and answer any questions or take your views into consideration as we take that information back to the Trust.
Yeah, I've got a question on paragraph 3.3, which refers to the reduction in the number of patients referred through the op centre. From the figures, it looks like about a 20% reduction over a year. Have you spoken to relevant GPs about why that is, and possibly finding out where patients are going if they're not going through the op centre?
Yeah, we have spoken to GPs and asked them. I think we need to improve our operations centre. It's a non-clinical service at the moment rather than a clinical service. And quite often GPs are actually looking for some clinical support to direct patients. We've put in so many new services to try and meet service need that actually it's the potential to be a bit confusing. So we have a new line in place to ring for gynaecology assessment. So GPs can ring gynaecology direct, so some patients are going there. They can ring surgery direct to get patients straight to surgery. We have plastics clinics, they can ring direct to get patients there. They can ring the ops centre. They're ringing our community hubs as well. They're ringing Frailty direct because they can get direct access to Frailty now. So although the work we've done to offer the services is good, we certainly have improvements to make. And our GPs are saying that actually a single line, which might be supported by clinical staff, maybe a nurse or therapist to direct to places, would give us a better understanding of who's using what service when, because the services around this are very, very busy.
Can I just come back on this one? Have you done an assessment of how many people are being directed by GPs to the emergency department instead of ringing the ops centre, or being directed to Dewsbury, should I say, or Pinderfields, instead of ringing the ops centre first? Have you done an assessment as to whether these numbers are, as you say, they want a clinical person, but also have some of them stopped or not using it properly at all?
We have done an assessment, yes. We count how many GP patients go to A&E, whether that be at Dewsbury or at Pinderfields, and those that have rung the ops centre and those that haven't rung the ops centre. Sometimes it's entirely appropriate for GP patients to go to A&E because they've seen them and they're very poorly and they want resuscitation. So that's an entirely appropriate pathway. We are working with our GP colleagues to understand why some GPs choose to always refer patients to A&E and not use the ops centre, and some always use the ops centre and not refer. And there are pockets of practices which seem to have a behaviour that's learned or is easier. So we need to work collectively to understand why that is, which is why we've met with our GPs to ask them. And that's where they've told us we need to improve our operations centre. So we do monitor it very carefully.
So what you're saying is GPs convert their problem into yours and you get inappropriate referrals?
I wouldn't call the referrals inappropriate, and we have to be very careful with our language because we can say we have inappropriate attendances, we can say we have inappropriate referrals, and we're very much trying to change our language to say if someone is referring a patient to us, there is a reason for that. It might be that there's a better option, but at that point in time, they made a decision with the knowledge they had that the most appropriate place to refer that patient was to us. In the same way, if patients arrive at A&E and they don't really need to be there, they made a choice to come there. So we're trying to work to say, how could we put better information out to help people make choices that would be more suitable? But if a patient arrives or a GP referral arrives, we deal with it as appropriate and the best way we can. I wouldn't like to say that GPs are just moving patients to us. We're working really closely together to try and make sure that we do collaborate, and there is definitely improvements that can be made, but I do feel they have a very strong voice and are very clear about the opportunities that we need to take to improve things.
Thank you. My principal question was really about the ANPs and what academic level and what level of competence are you training them towards, please?
Yeah, so they are, can you hear me okay? Can you hear me okay? No, I'll move a bit closer. So the advanced practitioners are either qualified nurses or qualified other physicians who will have already gone through a university degree process, and then they go on to do an additional course up to master's level in order that they can become autonomous practitioners, so work within their own scope of practice. They will have a clinical lead that will be a consultant consultant medic, and they will support them through their prescribing course and their assessment skills with regards to seeing patients. And whilst they're under training, they're obviously under a supervision, and it's a collaborative way of working between the consultants and the practitioners as to what level of support is required. And somebody in the first year of training is going to require much more support than somebody who's more further into the training. But until they are fully competent, you wouldn't leave them in an environment without that supervision.
So it's linked to an M level. It's linked to an M level course.
It is, yeah.
Can we ask as well, so have you done any evaluations on any admissions that would have been avoided if there'd been ambulatory care at Dewsbury, and any transfers that would have been avoided if there'd been any ambulatory care at Dewsbury? You say people can go straight into the frailty wards. Well, the frailty wards have to have spaces, do they not? And they have been known to be full from time to time. Have you done any assessments of the additional impacts across the hospital services by not having that ambulatory care and the ambulance service, by not having that care in Dewsbury at all, other than what you've got in this paper?
Yes, we have lots of information, and it's not all within this paper, and I think that is a weakness that we need to improve and share with you. Overall, our admission rate has fallen, so we are admitting less patients at the minute, whether that be from Dewsbury or from Pinderfields. Our admission rate is now one of the lowest in the country because of the additionality of services that we are offering. We have a full range of alternative services available, and some of those do mean that patients from Kirklees do come to Wakefield, and a lot of that is because the specialty provision is on the Wakefield site. So plastic services, for example, or cardiology is all on the Wakefield site. So there are transfers of care where the specialty input is needed. We can, as part of the review that we're doing with our commissioning colleagues, look at the totality of service provision and provide you with a more comprehensive paper on what's happening to patients from Kirklees from point of arrival, and then access points into the hospital and around the hospital, rather than just focus on this element of service, which actually does give quite a narrow view of what's happening. But we can provide that for either your next meeting or the one after that, whichever your agenda meets.
Yeah, mine's really a specific point around that sort of area, and it's from looking at Appendix 1, which was the report which came to our October meeting, and it's talking about patients who, it's in the summary at the back, patients who self-present to A&E in Dewsbury, then are assessed as needing ambulatory care, and then provision of hospital transport to get to Wakefield. How is that working in practice? Are patients satisfied with that transfer process in terms of how long it takes to get it?
The answer is yeah. The patients, we get really positive feedback from patients. If patients self-present into the ED department at Dewsbury, the clinicians there will make a decision as to whether they will treat them on site there or whether there needs the expertise of the centralised ambulatory care over on the Pinderfield site, and they'll make that decision and then discuss that with the patients, and we provide that support and that transfer over for patients if that's the appropriate way. We have got really positive friends and family responses through our ED department. It's one of the highest areas with regards to Dewsbury from a numbers of patients who respond, but also what they say about the services that they deliver there. We monitor concerns and complaints, whether they come through informally or formally, in relation to the services that are provided. We do regular walk-rounds, obviously on all of the sites, and we meet regularly with colleagues across the system, and they come in and do walk-rounds as well as do the MPs, and the feeling is very, very positive. as is reflected recently in the CQC report as well from the Dewsbury site. Sorry.
Can we ask what the level of weight is for transfer between Dewsbury and Pinderfields then? I take it will vary, but what is your top and what is your lowest level of weight for transfer?
With regards to transfers for ambulatory care patients, so again, it is dependent, but these are ambulatory patients, so often they are well enough to either come over in hospital transport that's provided in terms of the minibus shuttle, or they can even come over in their own transport, but the clinician will make that decision and discuss that with the patients. Well, it's a same-day service, so it depends which level of transport they're going to come across in. The numbers are obviously around 7 or 8 a day, so we can get some more information, but it would be dependent on emergency or hospital transport.
Right, well, it feels a bit as if what you're saying is everything's great, you know, everything's fine, you need a bit more work here and there, but you're going to review in another 6 months, but you feel there isn't really much of an impact, and it does feel a bit as if and how do I put this? It does feel a bit as if you're sort of talking towards a situation where there may not be ambulatory care in Dewsbury at all. That does feel a bit as if a direction, a little bit as to where it's going, I think. Has anybody else got that sort of impression?
When does temporary become permanent?
Yes, yes. Reviewing it in 6 months means that it will have been closed then for 12 months. So I think, do we feel we need some more detailed scrutiny into this rather than waiting for 6 months? Yes. So the proposals are that we will have some detailed scrutiny into this, just not a paper back at the next meeting, some actual detailed scrutiny that we would have for any service change. And look into this in far greater detail and want far more information. Now, we will talk to the colleagues in Wakefield as to whether they wish to be part of the scrutiny looking at ambulatory care across Mid Yorkshire, or whether we do it ourselves, just looking at Dewsbury and the impacts across to Pinderfields. And we will be in touch with yourselves and the CCG, because we would want the CCG's perspective on this as well in all of this, as to when decisions are going to be made and what the CCG requirements are for commission service here. This was a key area, a service that was put in as part of reconfiguration. I understand that you closed it on safety grounds because of the lack of staff. I understand that completely. But I think we do need far greater scrutiny into this area of service to see what other avenues have been put in. Because you've said that things have changed and the GPs want a clinical person on the other end of the telephone as well. So we need to understand far more about it. Okay. All right. So we will either have scrutiny here in Kirklees or scrutiny across Wakefield and Kirklees. Okay. All right. Thank you very much. Right then, the work plan then I think is as is in March. We may have mental health rehabilitation, or it may come in April. We will have the outcomes of the Kirklees Adult Safety Board Peer Challenge and an update on the wellness model on the meeting on the 12th of March, and anything that comes in the meantime. Can I just mention as well that there was a paper that went to the West Yorkshire panel on vascular services. This will again be discussed at Friday, at the Kirklees and Calderdale panel on the possible impacts on the Kirklees and Huddersfield Foundation Trust as to the proposals that are being put forward by NHS England. Okay, thank you. Thank you.